Hi everyone, welcome back to week 6 of our course. This week we'll be talking about some really core concepts to the sociology of health and illness or social medicine, medicalization and pharmaceuticalization. A couple big words there, but these are going to be really crucial, very core concepts as we move forward through this class. So let's jump into it. All right, so medicalization, what does that mean? This is essentially a process, hence the ization suffix, by which conditions, processes, body functions, or experiences and emotional states are redefined and then treated as medical issues. So essentially, a non-medical issue or a just general human experience exists. It becomes redefined as a medical issue through the process of medicalization, and then it is from there forward understood as a medical issue and something in need of treatment, medical research, and potentially seen as a pathology when it might not necessarily be anything other than a typical human experience. Another core facet of medicalization is this growing influence and authority that the health industry has, particularly within the West, within the United States. We have this idea that the experts, the doctors, the medical professionals, they are the end-all be-all authority on bodies, on biology, on medical issues, and that if something is labeled as a medical issue by these medical authorities, then that is true, that is the case. But we'll see that it's not quite so cut and dry, not quite so black and white, and this process is a little bit messier than it might seem on the surface. There's also a lot of reasons why something might become medicalized or be reframed as a medical issue beyond just, you know, hard objective biological evidence of something such as like a viral infection. When we look at other examples such as menstruation, menopause, body weight, and so on. So here we have a few examples to really solidify what this concept of medicalization looks like. We have some conditions such as sexual dysfunction and libido, particularly in AFAB individuals or those assigned female at birth. We have this in the DSM labeled as female sexual arousal disorder. That's just one of many examples of medicalization, but essentially in this case, we're taking the human experience of having a low libido and then labeling it as sexual dysfunction or a pathology and giving it that diagnostic label of female sexual arousal disorder. Interestingly, we've got this gender element here as well. This is not something that exists in the DSM, the Diagnostic and Statistical Manual of Mental Illnesses, the book that psychiatrists and psychologists use to diagnose mental disorders. Um, it's very interesting here that we see this diagnostic label present or available only for AFAB individuals. We also have other examples such as learning difficulties being labeled as different kinds of intellectual or possibly developmental disabilities. Eating disorders have been heavily medicalized. Addictions as well. We often hear addiction discussed as a disease. Really interesting to think about, what is a disease and why does addiction possibly fit or not fit into that kind of label. We also see PMS, premenstrual syndrome, menstruation, and menopause being medicalized. Um, Certain moods or intensities of moods in particular, like anxiety and anger, at certain levels of intensity, we might start to label those as possibly mental illnesses or other kinds of pathologies. We also see childbirth being heavily medicalized. We will dive into that in a little bit more detail in the following slides. Aging and, of course, death and dying also have been very heavily medicalized. All of these things are just normal parts of the human experience. They're not necessarily medical until we understand them that way. And understanding them as medical issues, or at least as something that the medical sphere can have a part in assisting with, there are benefits to that. But there can also be some downsides, and this can be kind of a messy process. So let's talk a little bit more about what medicalization can look like in practice. So one of the big reasons why medicalization is so prevalent, especially in the Western world and in the United States, is that it is profitable. That's not to say that all doctors who are diagnosing people are just trying to make a quick buck, But this is to say that the medical institution does make money off of the process of medicalization, leading to more medical conditions existing, more patients being treated. Because the more people who are diagnosed with something, the more people are going to be returning to their practitioners, putting in insurance claims, buying pharmaceuticals, buying treatments. So we see the outcome, even in kind of a roundabout way, in a correlation kind of way, that when medicalization occurs, profits can and do increase for the medical industry. And so we have to consider, in this case, is there a possibility that medicalization might, in some cases, take place for the sake of generating profits? And the answer would be yes, in some cases. We do see a lot of examples of this, which we'll discuss in the following slides. This is not to say that, of course, every single time medicalization occurs or that every time a human experience is medicalized, that it is for the sake of profit alone, right? There are a lot of doctors, there are a lot of practitioners and researchers out there who are really just trying to help people and learn more about the human body and about um, disease, illness, and different treatments for diseases and illnesses. But what we will see in kind of a roundabout way, again, as maybe a side effect of this process, is that profit for the medical industry. It's not always ethical, but it's not always unethical either. There's some gray area, and it really kind of depends, just like so many things in sociology. Switching gears for a moment to talk about pharmaceuticalization, try to spell that word backwards. Pharmaceuticalization is, again, another process, hence that ization suffix, of essentially medicalization with a pharmaceutical focus. So we're, in this case, seeing an increase in the recommendations for use of different pharmaceuticals, the sale of more pharmaceuticals as treatments for different kinds of conditions, particularly conditions that have been medicalized, or when we see a condition become medicalized, it is very likely that we will also see an increase in the development, research, prescription, and use of different kinds of pharmaceuticals. This does, of course, generate profits for the pharmaceutical industry, or big pharma, as a lot of people like to say. That doesn't have to be a bad thing, but it is something we should acknowledge. Sometimes medications are developed and sold with purely the purpose of increasing profits. And so we have to think, where is this research coming from? Who is doing research on these medications and why? What is the purpose of this medication? What's it meant to treat? And is it effective? Um, Whenever we see new pharmaceuticals coming out on the market, it's really important that we look at the stakeholders in the development of those pharmaceuticals, who funded that research, and is there possibly any kind of conflict of interest where a company is funding research on their own products that they want to sell for a profit. That can be potentially problematic and potentially unethical. So it's really important that we dive into those details when we're looking at this process of pharmaceuticalization and this increased use in pharmaceuticals to treat a lot of different kinds of conditions, medical or medically recognized or otherwise, um, because there are some potential downsides to the use of pharmaceuticals if it's not the appropriate pharmaceutical for a particular condition, or if it's just not really well researched. The FDA is pretty good in the United States about making sure that safe things end up on the market, but there are a lot of supplements out there that are, in a sense, part of the pharmaceutical industry, but that are not FDA regulated. So it's important, when we're engaging with pharmaceutical use, that we are aware of all of these different kinds of facets and factors in the safety and efficacy of these kinds of treatments. A couple examples of pharmaceuticalization to make this concept a little bit clearer. We have a lot of medications that have been developed for ADHD, attention deficit hyperactive disorder. Ritalin is just one of many. That is, of course, not to say that Ritalin is not useful, or that ADHD is not real, or that medicalization of ADHD is, faulty in some way. But what we do see is that a lot of people with this diagnosis are automatically given prescriptions for these types of stimulant medications. And we need to make sure that we're being very careful as prescribers or as medical practitioners, that when we do these diagnostics, we are being very careful not to misdiagnose, overdiagnose, underdiagnose, or really just, trying to avoid mistakes in that process because there are major consequences to using prescriptions that are not appropriate for a person's individual situation. So we see this increase of prescribing Ritalin for ADHD, as well as other stimulant medications, kind of this process of saying pharmaceuticals are the answer, are the solution to this so-called problem. Um, ADHD for many people might be seen more as a neurotype or a form of neurodivergence rather than a pathology or a disease or something that's wrong with that person. It could just be a different form of experiencing, um, human life, the human experience. We also see, of course, weight loss drugs. We see first the medicalization of body weight, especially higher body weights, and then the prescription of weight loss drugs or the use of those pharmaceuticals, whether by the recommendation of a physician or otherwise. A lot of psychiatric medications also are being prescribed at really, really high rates. That's not to say that they're not helpful, but for a lot of individuals, particularly with mood disorders, certain moods and certain intensities of moods, certain experiences of emotion have been labeled as pathological, have been turned into or given the label of different mental disorders. And so in those cases, we can look to the DSM and see all these different human experiences, all these different emotions that have been medicalized, and then that pharmaceuticalization, where we're saying, okay, here is the solution, pharmaceuticals. We also see examples like Viagra, a medication used for erectile dysfunction. Again, another human experience that we have medicalized and start to see as a pathology or a problem. Nicotine gum can be used for quitting smoking. We also see a lot of different sleep aid medications for insomnia or trouble sleeping. We see this really huge prevalence of prescribing and using pharmaceutical intervention. And again, we need to question if that's always the best approach. Pharmaceuticals, pharmaceuticals can be really, really useful for a lot of individuals in a lot of different situations, but the rate at which they're being prescribed is incredibly high. And so sometimes we have to think, is this just kind of a band-aid approach, and is there potentially something underlying that we could also do as far as lifestyle adjustments, talk therapy, interpersonal communication, or changing other things in a person's life that could potentially benefit their health in a way that does not necessitate or does not rely so heavily on the use of pharmaceuticals. For a lot of people, pharmaceuticals are life-saving, but for a lot of people, they are also not necessary or not the most helpful treatment. And so this concept of pharmaceuticalization is a little bit critical, at least in sociology of medicine, of this really heavy reliance on pharmaceuticals rather than any other options. Getting a little bit more into the topic of mental health and medicalization, we can talk a little bit more about the DSM. The DSM is notorious within the sociology of medicine. I'm sorry for any psych majors out there, but it's really important that we be critical of these social constructs of health and illness, particularly mental illness. And so in the DSM, we see a lot of human experiences that are labeled as mental disorders or mental illnesses. And this is not to say that mental illnesses do not exist, but we want to acknowledge the fact that all of these labels are socially constructed. They are decided on by a committee of people at the American Psychiatric Association. And we need to think about, who are the people making these determinations, creating these diagnostic criteria, creating these labels, and why? How are these diagnostic categories helpful? How might they be potentially not helpful? Why do they change so often? So this diagnostic criteria, it is socially constructed. It is something that is essentially made up by people to categorize and understand our experiences and our world. And it can be a little bit messy. It could be a little bit problematic at times. And so it's really interesting to look at the history of these processes of medicalization with mental health. A couple examples that we've talked about, female sexual arousal disorder is currently in the DSM to describe low libido among AFAB people. We also saw homosexuality up until 1980. It was listed as a sociopathic personality disturbance. We can see, of course, now how problematic that perspective is. But for quite a long period of time, homosexuality was seen as a pathology or a disease or a problem with a person or with their brain, their body, their existence, in a way that was very heavily medicalized. We also see that a lot of transgender people or gender nonconforming individuals today are diagnosed with gender identity disorder. We also have seen gender dysphoria as one diagnostic label in the DSM as well. And again, all these labels are created by a committee of people trying to label, categorize, and understand our experiences and our world. But it's really important that when these decisions are being made, that people are being included and represented in that committee, and that's not always the case. Um, I don't know for sure who is sitting on the board at the APA right at this moment, but we do know that throughout a lot of our history with medical research and psychiatry, um, really the whole medical field in general, there was not a lot of representation of LGBTQ plus individuals, women, gender nonconforming people, people of color. There were a lot of, straight white men who were filling these kinds of roles, and even today that is still the case in a lot of scenarios. And so the results that we see from that population being those who contribute to medicalization and construct these diagnostic criteria, that can give us kind of a skewed and different perspective than people within those communities or who have those experiences themselves might develop instead. Um, these diagnoses, really anything in the DSM, but particularly the ones listed here as well, are treated with different, pharmaceuticals, different therapies that can be helpful. But of course, we know that things like homosexuality in like the 70s and 80s was being treated through things like conversion therapy, spending time in asylums, and a lot of other really problematic practices. Another thing that is important to acknowledge as well within the whole field of psychology and psychiatry, and I say this as someone who I was a therapist for a little over half a decade, so I spent quite a lot of time in this world. It is very, very individualized, and that is, we can blame neoliberalism for that if we would like to. We can blame the Western individualization or individualism for that, but really the way that we approach psychology and psychiatry in the US is very individualized. That's not necessarily a bad thing, but what that does tend to give us is a lack of focus on social and cultural factors that lead to mental health struggles or potential mental illnesses. A lot of individuals have things going on outside of themselves, outside of their coping skills, their lifestyle habits, or their own biology that is really like the main contributing factor to their experiences of mental illness or struggles with mental health. So, of course, the DSM is a product of our culture. Those who are developing it are not in a vacuum, they're not perfectly objective. These are things that are being socially constructed, and these are experiences that are being medicalized to potentially be a very helpful tool, but there can also be, of course, these tricky and potentially problematic outcomes as well. All right, here we have a quote straight from one of our readings this week. I'll read to you. It says, disorders become medicalized when it is claimed, without any supporting research evidence, that they are caused by genetic deficiencies, chemical imbalances, or other biological phenomena. Again, this is kind of criticizing that very medical model, bioessentialist, and individualistic approach to diagnostics, where we're looking at things like genetics and chemicals within that individual's brain rather than looking at their sociocultural context or things outside of that individual, because we really do need to include that to get that full, well-rounded picture of a person's mental health. And so medicalization is something that is pretty heavily criticized within the sociology of medicine when it is done for reasons such as profit seeking or in ways that ignore that social and cultural context, because that's really just missing a big part of the picture. Here, we of course can't have an actual discussion over video, but I'd like you to think about what are some things that can contribute to mental health struggles besides these biological explanations. We tend to focus on these things like genetics or chemicals or biology, but there's a lot going on besides just the biology of an individual when it comes to mental health difficulties. Someone who is completely so-called healthy with their biology could have mental health struggles because of the situations that they're living in. Maybe their socioeconomic status is causing stress, and they've got this um, maybe potentially food insecurity or housing insecurity or interpersonal difficulties. There are so many things that can contribute to poor mental health or mental health struggles besides these biological, bioessentialist, very individualistic kinds of explanations. So it's very important that we recognize that and that we see in the social construction of mental illnesses that there's a little bit more to the picture compared to what we tend to focus on. All right, so now we come to one of my favorite topics of this lecture and of our entire class, the medicalization of sex and gender. This can be kind of a difficult topic for some people to learn about. This is going to go maybe a little bit against things that you might believe or have heard previously, so please try to keep an open mind as we journey through this topic. A little bit of background information about some of the terms that we're going to use. First, sex. This word refers to the biological categories that are determined by the traits of the physical body. So a person's sex includes their internal and external anatomical structures. So internal structures could be things like the uterus, uterine tubes, ovaries, the vagina. External structures could be testicles, the penis, clitoris, labia, all of those anatomical structures. We also want to look for a person's hormone makeup when determining their sex. So the different levels of things like testosterone and estrogen that that person has. Every single individual on Earth, every human being has all different kinds of hormones. Everybody has testosterone, everybody has estrogen. We all just have it in varying levels. And then we can also look at genetic factors such as sex chromosomes to determine a person's sex. So it's not just any one of these bullet points. We have to look at all three to determine what a person's sex is. And we'll talk a little bit about some of the variations that we can see when we're looking at all these categories when it comes to human biology. When we're talking about gender, specifically in sociology, but also in general, sex and gender are not the same thing. They're not synonyms. They are different. Gender refers to identity categories that are aligned with your own personal identification with masculinity, femininity, and or androgyny. This could be your internal sense of these experiences. It could also be your external expression of masculinity, femininity, or androgyny. Androgyny being kind of a blending between masculinity or femininity, or kind of going outside of those categories as we typically understand them. And so gender and sex, for the sake of our course and sociology in general, they are not the same. Sex is looking at biology, gender is looking at identity, masculinity, femininity, and androgyny. So before we get into some details about medicalization in this process, let's talk about a couple misconceptions. Let's bust some myths here. One really common myth that we hear in the United States is that there are only two sexes, male and female. And one of the really cool things about human biology is that biology really doesn't follow binaries. Biology and nature like to be on spectrums. There's a lot more variation than we tend to see with the naked eye and that we tend to recognize in our society. So there are actually a lot of different biological sexes possible. Again, looking at that biology of internal and external anatomy, hormone makeup, and chromosomes, we have 6 chromosomal sexes in humans. And these are not incredibly rare, not anything that is necessarily problematic or unhealthy. These are just very normal parts of human variation. And we tend not to talk about this very often in our society, but a lot of individuals might have these differences in chromosomes, and they might not ever even know. Typically, we hear that XX chromosomes are female chromosomes, XY chromosomes are male chromosomes, or that the Y chromosome makes a person male. But we also see XXY, X0, so someone who has only one X chromosome, XYY, XXXY, and there are a few other options as well, but some of the other options as far as chromosomal sexes are a little bit rarer. So these are the 6 most common that we see in humans. Another myth is that you can tell a person's gender identity just by their appearance. Again, gender is about identity. It's about your personal sense of self as well as your expression. So this is very personal, and a person's appearance, the way that they present themselves to the world, doesn't necessarily give you all of the clues as to how they identify or see themselves. So we really can't assume just based on somebody's appearance how they see themselves, how they experience their gender, how much masculinity they feel, how much femininity, or how much androgyny they're in touch with their own personal identity. So it's going to vary a lot depending on the individual from person to person. And so it's important that we don't have these assumptions that, what a person looks like is really all there is to it. There's a lot more going on under the surface amongst every single one of us. All right, so let's talk a little bit about intersex individuals. This is an excellent example of medicalization of sex and gender. So intersex people are individuals whose bodies don't fit directly into the binary categories of male and female, particularly when we're looking at biology. So we're looking at sex here. There are over 30 different types of ways to be intersex. So some of those chromosome differences that we talked about, people who don't have XX or XY, but who might have XXY, XYY, X0, XXXY, any of these other chromosomal differences, they could be classified as intersex people. A lot of people will actually never know that they are intersex. One great example would be Caster Semenya, the Olympic runner. She did, of course, find out, and there was a whole kind of debacle over that we will discuss a little bit in a moment. But there are people who have XY chromosomes that we typically understand to be male chromosomes who can have something called androgen insensitivity syndrome. And in that case, you have XY chromosomes, but your body is insensitive to androgens, meaning it doesn't respond to testosterone to develop in a way that is typically male. So people can have XY chromosomes and develop typically female anatomy. So, an internal uterus, ovaries, they might menstruate. They'll go through a female puberty, and they will have XY chromosomes. A lot of people in that situation, they can get pregnant, they can have children, they will likely never know that they are intersex. So there's a lot of variation out there amongst biology and the way that human bodies can work. It's really, really fascinating. So of course, we talked a little bit about chromosome differences there. We also can see some anatomical differences amongst some intersex individuals. Some people will have what we call ambiguous external genitalia. So this could be external genitalia that's visible, to the naked eye without any imaging, where a person might have, like, I'm blanking a little bit here, um, either what looks to be too small of a penis or too large of a clitoris, kind of just this in-between type of genitalia that is not quite clearly a penis, not quite clearly a vulva. And in that case, that person may be considered intersex. We can also see internal structures that don't fit in the binary. So someone who has an external penis and testicles who also has internal ovaries and so on. We see a lot of different variation amongst this population. We also can see, of course, hormone profiles that don't fit into the typical binary expectations. So this could be like an AFAB individual, someone assigned female at birth who has really high androgen levels. This could be someone with androgen insensitivity syndrome. This also could be somebody with PCOS, polycystic ovarian syndrome. That wouldn't necessarily make them intersex. So there's a lot of variation here. There's a lot of very colorful differentiation, and it's really, it's such a spectrum. It's not easy to chunk people into these clear categories when it comes to sex. And I think that's really one of the biggest myths that we have in the West is that there's just male and there's just female, and that's the end of the story. We have a whole lot more options. We have over 30 different ways, like dozens of options when it comes to just the biology alone we're not even looking at identity or gender expression. I think this fact is also really, really amazing. It is actually more common to be intersex than to be a redhead. It's also about just as common as being a twin. So about 2% of people, like 2 out of every 100 people, are intersex. Only 1% of people are redheads. So if you think about every time you've met someone with red hair, every time you've met someone who is a twin, you have met intersex people more often or equally as often as you've met people who are redheaded or twins. So it's actually pretty common, and that's just the people that we know are intersex. There are probably tons more people. This percentage might actually be quite a bit higher because there are just a lot of individuals that will never know that they are intersex. So really, really important stuff here. Here I have just a few examples of some famous intersex individuals. You may or may not be familiar with these individuals here. I did mention Caster Semenya just a moment ago, down here at the bottom left of the slide. She's an Olympic runner who had several medals and then was discovered essentially to be intersex with androgen insensitivity syndrome. So she had XY chromosomes but had developed a typically female body and had no knowledge of this prior to that discovery through some testing. And so, a very interesting case there. She was originally stripped of her medals and they were eventually returned, but there was a lot of debate about, should we let intersex individuals participate? Is this fair? Very similar to the debate that we hear about transgender athletes and this exclusion or this intention to exclude trans people from participating in sports due to, again, a lot of misconceptions about how biology and sex work, but also gender identity. So I really encourage you to look into the intersex community more, learn about it, learn particularly from intersex creators. Personally, I am not intersex as far as I'm aware, and so I'm not speaking for the community as far as, you know, it's not my personal experience, but there are a lot of amazing creators out there that you can find on social media, places like YouTube and stuff as well, if you want that longer video content. And it's really cool to learn more about this community because they are a really, really large community that gets pretty much overlooked by most of our society. So looking kind of at a darker side of the history here with medicalization of intersex bodies, we have seen that, while intersexuality is a normal part of human variation, it is not unhealthy whatsoever. There are no health concerns related to being intersex. But we have seen the medical field take intersex people and say, this is a pathology, this is a problem, you need treatment. This is bad. This is not okay. Um, and some of the really terrible outcomes of that perspective of that medicalization have been IGM. This is intersex genital mutilation, which is non-consensual surgeries done on very young children or even babies, people who are born particularly with that ambiguous external genitalia. And so in these cases, a lot of the time, if a baby is born with that ambiguous genitalia, um, they will be non-consensually subjected to surgery to correct that anatomy. This is essentially just aesthetic plastic surgery. There is no health problem, no health risks associated with that kind of anatomy. It's just part of being a human. We also see hormone therapies. A lot of the time, intersex people are given hormone therapies. This can be useful for a lot of individuals, but a lot of people are given hormone therapies, especially as children. They may not even know why. And this is intended to correct the hormone profile of that person or their body in a way that is really not necessary. So when we see this medicalization of intersexuality happening, there are some negative effects. There are some very harmful, life-changing, life-altering, and unconsensual, non-consensual practices that are being done to this population that is really, really concerning. There is a lot of activism within the intersex community and the gender nonconforming community pushing against these practices, and things are improving in a lot of ways, but it's very slow progress. I think also on this topic, it's very interesting to compare the acceptance of IgM, of doing surgeries on babies to essentially fit them into the gender binary. There's not a lot of outrage about that. It's pretty accepted by a lot of individuals. And on the contrary, we see a lot of outrage and upset about surgeries on transgender children, which are actually not happening. Um, Surgeries, especially, gender reassignment surgeries or gender confirmation surgeries and hormone therapies are not typically being done on young children who are transgender or who have a gender identity outside of the binary or that doesn't fit, expectations. But those whose bodies do naturally, intersex children, are being subjected to these kinds of treatments. So the injustices that are happening to both of these communities are similar in a lot of ways, in a way that is definitely worth investigating and understanding, so that the next time you get into a conversation with someone about these topics, you can be a little bit more informed about um, what is really happening, and why is it happening, and what are some of the problems that are taking place that we really should be working to correct. So switching gears now to talk a little bit about medicalization of body size as well as the concept of fat phobia. In the West, and specifically in the United States, we have this perspective that looks at body size and body weight as an individual choice or an individual's fault. And we also tend to see higher body weights as a medical problem or as a pathology. And so we have this push to, solve or correct or cure a person's weight problem. And that individual is really seen as responsible for doing that solving. You are responsible for seeking out the cure for the problem with your body. And that perspective we can call fat phobia. Within sociology of medicine and sociology in general, we tend to say that people with larger bodies, fat individuals, are discriminated against and oppressed in our society. We see a lot of evidence of that. We can talk about some examples of that oppression, but that is the result of fat phobia as well as this medicalization of body size and body weight. We see a lot of jokes in the media. We've probably all seen movies or TV shows where characters with larger bodies are kind of the butt of the joke. We also see a lack of variety in clothing choices for those with larger bodies. We tend to see either very uninteresting or unflattering or just, not a lot of options as far as clothing choices. That could be really, really limiting to people who have larger bodies. We also see, of course, the built environment being inaccessible, plane seats or movie theater seats or chairs in general, beds. There are a lot of different kinds of infrastructure that are not built, not designed for people with larger bodies or who need more space. And that could be seen as a result of fat phobia as well within our society. Finally, we also have healthcare mistreatment, medical practitioners or professionals treating people with larger bodies badly, doing medical gaslighting, being dismissive, or chalking up medical concerns purely to a person's body weight. These are all problems that we tend to see happening, not just in the United States, but these are very, very prevalent issues within the US. I said finally about healthcare mistreatment, but we do have another example here of interpersonal discrimination. This could be fat phobia from one person directly to another. This could take the form of bullying, rejections for jobs, rejections for rental applications or mortgages, or potentially in the dating sphere. There's a lot of different examples that we could see of interpersonal discrimination against people with larger bodies. And then finally, of course, social scientists as well as medical practitioners tend to overlook this population, tend not to include people with larger bodies or fat individuals in research all the time. And that can be really problematic because we're not getting that well-rounded representative sample when we're looking at human interactions, social phenomena. We really want to include everybody and get these really representative, well-rounded samples when we're doing research. And so Our reading this week really criticized that the lack of focus that a lot of social scientists and sociologists have had when researching this population or researching other issues and just excluding this population from the sample. All right, so what does it really mean to medicalize body weight? We have seen a shift over time over the last few centuries, particularly the last few decades even, of this perception of larger bodies going from positive to negative. Through a lot of human history, having a larger body or a higher body weight was seen as a positive thing. And more recently, especially in the last few decades, we tend to see this as a very negative thing within our society. We have this very fat phobic, discriminatory kind of perspective. We also saw in the last few decades the invention of BMI or body mass index. I have a little graph here on the corner of the slide of BMI as it stands today. Essentially, the invention of BMI was creating this metric to label and categorize people's weight based off of their height. And I'm sure a lot of you are aware of the potential problems with BMI, especially for people who are very tall, very short, who have a lot of muscle mass, potentially a higher body weight because of that muscle mass as well. Using BMI as a metric for health is potentially problematic because of all of those different factors, because a person's weight and height alone really don't tell you too much about their health. There are a lot of other factors at play. What we did see specifically starting in the 50s and really ramping up, especially into the modern day, we saw a lot of governments, the US government included, and pharmaceutical companies campaigning to promote this idea that BMI is the ultimate marker of health and that people have to individually solve the problem of their weight if it's too high. So this idea that once BMI was invented, a bunch of people were automatically classified as overweight or obese, and those individuals were then told, okay, you have been medicalized, you now need to seek out treatment, seek out pharmaceuticals, and cure your problem. We saw a lot of fear mongering in these kinds of campaigns, a lot of pushing for national health campaigns that was done in a very fat phobic and problematic way, a very victim blaming kind of way. And there was a lot of fear mongering, a lot of misinformation, a lot of very exaggerated information. And the really tricky thing about this is that a lot of individuals, excuse me, a lot of pharmaceutical research is actually funded by the pharmaceutical companies that are seeking to sell and profit from those pharmaceuticals. Particularly weight loss drugs, those are very often researched by stakeholders who have, really have a stake in making sure that those drugs are, promoted as safe, promoted as weight loss treatments, and that can be actually potentially pretty harmful to a lot of people's health when that research is not done in a completely objective way that is not funded by stakeholders in the promotion and sale of those pharmaceuticals. It's really interesting that a lot of the research tends to skew in the direction of saying that higher body weights are unhealthy, that being obese or overweight is really, really bad for your health, when we have very mixed research on this actually. We do tend to see that people who are classified as underweight by that BMI scale actually have higher mortality than those who are classified as overweight. But instead, we have this focus, especially in the medical field, on overweight or higher body weight people instead of underweight people who actually have that higher mortality rate. So we have this bias, this stigma against higher body weight people that is really skewing how we do our research, what kind of pharmaceuticals are on the market and why, who is selling them, who is paying for that research, and really just the whole picture is not very objective, right? The information is very mixed. We do have some evidence that higher body weights are associated or correlated with certain kinds of health concerns, but we also see that for lower body weights or underweight people too. So we need this well-rounded full picture of the topic, as opposed to our medicalized perspective of just saying that higher body weights are bad, higher body weights are unhealthy, period, end of story. Go take care of it, go get treatment, go use pharmaceuticals when really it's not that simple. Um, Obesity as well as BMI and these categories and these labels are all social constructs. They have all been medicalized, and so we really need to look at what are the stakeholders doing this medicalization aiming for? What is the purpose? What is the goal? Why do we create these categories, and why are they potentially important? All of these different factors. So we talked about this a little bit already, but health marketing and the incredibly profitable weight loss industry are huge reasons why the medicalization of body weight has been very profitable and potentially can be seen as very problematic. So we have this huge, huge industry that is marketing all these weight loss treatments, products, medications, weight loss shakes, teas, all kinds of stuff like that. You probably see it all the time, billboards, advertisements on social media, it's everywhere. Um, this health market or the health industry, the weight loss industry, it is huge. It is super profitable, and um, the medicalization of body weight really facilitates the ability of this industry to continue to function as it does. Because as long as we're told that something, really anything, insert thing is unhealthy, is a medical problem, people will seek out treatments. People will believe there's something wrong with them, and they will seek treatments, they will seek care, they will try different things to try to correct that issue. But we have to really think, critically about this. Is body weight actually a medical issue? Again, the research is really mixed on this. We see different research telling us yes, different research telling us no, a lot of research saying it's inconclusive. And so it's important to be informed. It's important to do your own research and to take care of yourself in the way that is best for your own body. And what we really need to do away with is the shame, the stigma, and the pressure that we have in our very individualistic society saying that high body weights are bad and that it's this individual responsibility to correct one's body weight because that is a really, really harmful perspective that does a lot of damage to a lot of individuals, regardless of their body size. We see, of course, a lot of eating disorders in the West, particularly in the United States, and we can tie that back to this medicalization of body weight and to fat phobia and the health marketing industry. Um, so it's really important that we are critical of these processes and we look with a very discerning eye at these kinds of um, practices, processes, and these industries as well. When we're actually talking about things that contribute to a person's body weight, there is a lot more to it than the pharmaceutical industry, the weight loss industry, and the medical field might really focus on the surface. Big factors for body weight are going to be things like socioeconomic status. We tend to see higher body weights amongst people with lower socioeconomic status. A lot of the time, people who are low income have less access to nutrient dense foods, but they might have a lot of access to calorie rich foods on the contrary. Also, higher levels of stress and lower quality sleep are associated with higher body weight. A person's age as well, as people get older, they tend to have a higher body weight as time goes on. We also see a person's hormones and possibly also some genetic factors contributing to body weight. As well, we see a person's ability to exercise, whether it's disability or time or anything else that gets in the way of their ability to exercise, as well as the frequency and intensity of exercise that they can take part in being factors in body weight. Further, access to healthcare and the quality of healthcare that a person has access to, that can be a huge factor as well in what happens with that person's health and body weight over time. Further, we see the types of foods that a person has access to. A lot of the time, this is linked to socioeconomic status. That can be a factor in weight as well, and substance use habits such as use of drugs or alcohol, particularly substance abuse, depending on the substance, that can affect a person's body weight as well. So a lot of those things are actually not individual, right? Those are things that are big scale sociocultural factors. They may be environmental factors. They may be due to a lot of things that are completely outside of an individual's control. So our very individualistic perspective on body weight and weight gain and weight loss That can be particularly problematic when we overlook all of these other factors. Specifically in the medical sphere, it's very important that we have this well-rounded perspective and approach to understanding body weight and looking at all of these factors, all that social, cultural, and environmental context is really, really crucial. I mentioned a few of these already, but some of the consequences of medicalizing body size can be things like eating disorders, internalized fat phobia in people of all body sizes, potentially unnecessary and risky bariatric surgeries or weight loss surgeries. A lot of people might use dangerous or potentially health compromising weight loss drugs, pharmaceuticals, or other treatments. This is also, of course, generating great profits for potentially predatory corporations, unethical corporations that are marketing these kinds of products to us. And we also can, of course, be looking over the social causes of poor health in favor of victim blaming individuals. There are, of course, a lot of other consequences of medicalizing body size. These are just a few. But this is a very, very serious issue. This is one example of medicalization where we're taking something that is just a very normal human experience of just existing in a body and saying that certain bodies of certain sizes, of certain types are unhealthy. And then we get all of this just quick cascade of all these different consequences. So, in summary, there is a lot we could talk about when it comes to medicalization and pharmaceuticalization, and we'll actually cover a little bit more next week as well. But when we're talking about the topics we covered today, it's important that we know that it's messy. It's not a super cut and dry, super clear process to medicalize or to diagnose or define different disorders. There is a lot of disagreement and a lot of mixed information out there, particularly about body weight and health. I discussed this a little bit already, but we are not super sure about this relationship between body weight and health. We've got some correlation research. We're seeing that some research is showing that higher body weights are associated with different kinds of negative health events. But when we look at that research, we have to, of course, look at who funded that study. If a weight loss company gives money to researchers and says, hey, please go find out whether obesity leads to heart attacks, is that going to be completely objective research? Possibly not. Um, so we need to make sure that we're looking at who is funding research and that we're really looking at is this an objective study when we're looking at these relationships between not only body weight and health, but really any other factor and health. We've seen a lot of research in the past that looks at race and health in a way that frames race as, particularly for people of color, as something that is related to, poor health. What we tend to see in those relationships is actually that discrimination, disenfranchisement, socioeconomic status, and struggles with low income identities and depressions, um, economic depression, all of those kinds of factors are much more important. Um, a lot of these things are not really about biology. It's really going to be about that social, cultural, and environmental context. It's also, of course, it's super easy to become overwhelmed with all the information out there, regardless of what we're looking at, sex, gender, pregnancy, body weight, pharmaceuticals. There is so much information to sift through. Hopefully this class will give you some good tools to sift through that information a little bit more discerningly. But that media literacy, fact checking, those skills are so crucial when it comes to anything health related because there is so much misinformation out there. Finally, I want to close this lecture on this more wholesome note here. It's really important that you take care of yourself the best way that you can and the way that's best for you, whether that be your mental health, doing self-care, having support, and leaning on those support people and trusted professionals if you do have any health concerns. Nothing in this lecture was meant to be health advice or guidance. This is just a sociological look at some of these issues, some of these topics, and how medical sociology and the medical field understands these things. So I'll see you all back again next week. We'll talk a little bit more about medicalization and pharmaceuticalization.